Hi there, everyone. Hope you're all well there. Welcome to the Elastoplast taping and movement series. My name's Kertanegara. I'm the head physio at the Waratahs, and I hope you're all and your families are all keeping well in these unprecedented times. So before we start today's session, I just wanted to go through some housekeeping rules. So firstly, we're looking at this session going for around half an hour, and if you can hold our questions to the end, that'll be great. If you do have any questions, then feel free to shoot at any stage. I think the more the merrier at the end. Just add them to the chat box and then send them to the Elastoplast admin on the chat box if you can, and hopefully we'll get to all your questions at the end of the session. And lastly, if you could put your microphones on mute, that would be great. I've always wanted to say this, and finally we finish with a disclaimer. Always read the label, follow the instructions for use, and if symptoms persist, talk to your healthcare professional. Lastly, if you hear any background noise, I'm doing it from the sanctuary of my house. I've got 3 kids under 5, so if you hear any screams, I apologise. If you hear any tantrums, that's probably my wife freaking out in the middle of dinner and bath time. So today we've got a presentation. I'm just going to share my screen. Okay, so I hope everyone's got that. So today we're going to talk about the independent marker approach to rehabilitation and rehab. So when I initially came up with this content, it was we were a little bit more restricted within the COVID process, and I thought this would be a good idea for those with knee issues. In this particular case, and hopefully if you stay tuned to the second session, ankle, hamstring and calf issues, to rehabilitate themselves in this period. I can see the reluctance to see a healthcare professional at this time, and so the idea was to give you guys an understanding of how we approach rehab at the Waratahs and how we convert that to the average punter at home. So the BEIERSDORF products that we use in this particular in-service, we at the Waratahs use the LEUKO Premium Plus rigid strapping tape, 38mm. That's our stock standard tape that we use. We also overwrap with the LEUKO Band Light, hand tearable, either the 50mm or the 75mm. And in this particular case, the rugby player involved was a little bit more sensitive to tape, and so we use the hypoallergenic adhesive underwrap that Elastoplast provide. So we'll start off with the case study. This particular player sustained a grade 2 PCL injury in the last trial match before a season. So obviously concerning heading into the start of a Super Rugby season, and there was an acute mechanism and no previous history. So for those physios that are potentially on this call, that basically means that this is not an old PCL that was re-aggravated. This is a new PCL. He was the starting hooker for the Waratahs at the time, and he was unable to continue during the match, which is saying something because he's one particularly tough man, and it probably showed you that this injury was significant. So the question is, how long did this player take to return to play? So I think the world of physiotherapy is moving away from timeframes. So you probably heard media talk about they love 4 to 6 weeks. Things to always take 4 to 6 weeks. And that's based on, you know, soft tissue healing, ligamentous healing. You've got 2 weeks of rehab exercises, 2 weeks of rehab running, followed by, you know, 1 to 2 weeks of training, and that's your return to play. So that's just your time frame based on how things heal. However, the Waratahs, and probably I dare say most professional sporting organisations, are moving to a marker-based approach for rehabilitation. So that basically means progressing through stages of rehab based on markers. So it's pragmatic. It's attempting to be structured within the rehab process. So here's what it looks like for the knee anyway, for the Waratahs. So stage 1, you can commence graduated impact rehab exercises and modified lower body weights once you pass your stage 1 markers, and we'll go through them in a second. Once you do a few days or however long it takes for you to be in stage 1, you'll then attempt your stage 2 markers, and if they're achieved, you can commence rehab running and unrestricted lower body weights. Again, staying in stage 2 for a period of time, or however long it takes for you to pass your stage 3 markers, which is your commencement of your change of direction rehab, your unit primers. So in rugby union, that's your scrum and your line out, and then you commence your rehab contact. Again, you then have an opportunity to pass your stage 4 markers, which then returns you to unrestricted team training. And once you've performed enough team training, you're eligible for selection and therefore eligible for return to play. Now, there's a medical clause to this. This is all provided that you have enough ligamentous stability. And in this case, this particular player's PCL, although loose, had an end-feel, hence it was a grade 2. And you don't really need a PCL to play footy, to be fair with you, in most cases. And your progression through rehab stages should align with specialist recommendations. So we're fortunate enough to have a sports physician that works with us, and she was at the time more than happy to use the marker-based approach in this particular case. So what does that mean to the weekend warrior? And I disclose that this is a guide only for the average punter. So on the left, you'll see the Waratah markers, and on the right, you'll see what I've suggested as a guide for the markers for these particular stages of rehab for the average person. So your knee markers for return to weight-bearing strengthening. So weight-bearing strengthening would be things like squats, single leg squats, particularly for the knee. Perhaps if you're more inclined to the machine stuff, leg press, knee extension, but it's just, I guess, a marker for returning to strengthening of the muscles around the knee. So the Waratahs, we squat to a 50 centimetre box, so 50 centimetre box from the ground. If that's pain-free, if you have full extension of your knee, so if you can fully straighten out your knee, you can perform 60% of your single leg squats to a box for reps. So that's a lot of words, but basically we assess your unaffected side and see how many single leg squats you can do to a certain depth. And we assess that with a metronome to keep it consistent. And then we assess the affected side, and if you can get to about 60% or more of the reps that you've achieved on your unaffected side, then that's your marker ticked. And of course, pain-free day-to-day activities. So for the weekend warrior, we're suggesting a more conservative approach. Obviously, we're not pushing to get back for a game in most, or a professional game in most cases. So a pain-free squat would be something that we would suggest. Not just full extension or full straightening, but a full bend. Pain-free single leg squat in general. And most definitely pain-free day-to-day activity. So for the knee, that might be something like getting out of a car, going up and down stairs, things like that. So once you've done a little bit of weight-bearing strengthening, you're probably looking at, look, when do I start running? So at the Waratahs, we use these markers for assessing whether one can return to run. Making sure that they have an appropriate effusion. So in most cases, we'd like nothing. So that's effusion is swelling within the knee joint. So we'd like nothing in the knee with regards to swelling in the knee joint. But in some of these cases, these guys have pretty grotty knees, and that we had to give a little bit of leniency there. The 60% marker goes up to 80% for reps. 5 coordinated hops. So coordinated meaning that you're doing it with control and that you're not looking stiff, and you're pain-free on your modified lower body weights that you're performing in the gym with your strength and conditioning staff. So again, for the weekend warrior, we're looking at being a little bit more conservative. You're looking at maybe 10 pain-free hops, a single leg hop for distance test, which I'll demonstrate hopefully with any luck after this presentation. Some side hopping tests, again, which I'll demonstrate, and no swelling in the knee would be appropriate. And I'll make it clear, I think, for the weekend warrior, no swelling throughout the running process. I think if you're having recalcitrant swelling in your knee whilst you're trying to run, you definitely need to see either a doctor or a physio to assess what's going on, because that's not normal. So it's got to be pretty smooth along the running process. So you're returning to training, and hopefully with any luck, we're going to start returning to some type of ball sports, both at a professional level and at a weekend warrior level. Fingers crossed. So your assessment for return to training, your single leg squat for reps percentage increases to 90%. We expect a triple hop crossover hop test for the professional players. So I'm probably not going to demonstrate this in this small little room, but essentially what that means, it's you've got a line and you're hopping 3 times across the line, and we assess the distance from the start, and we assess it unaffected versus affected, and we're looking at within 90% of the unaffected side is a marker that's passed. Progression through rehab running, which is successful. So for the weekend warrior, that would be no pain, looking at things like increasing your straight line running, increasing your change of direction, etc., etc. And for the Waratahs, making sure that you're successfully able to complete a unit session. So for a forward, that's a full scrum. If you're a jumper and a line out, it's a full line out session. If you're a back, then you're probably looking at some launch plays, some set piece, etc., etc. For the weekend warrior, we're looking at progressing through running. So whatever program that you're familiar with. Again, if you're looking at returning to a sport that involves change of direction, then we need to do some change of direction in your running program. And definitely mini skills. So if you're an AFL player, for instance, getting a footy in your hand and making sure you build up your kicking from low distance kicks to medium distance kicks to full roofs. If you're looking at footy, getting your ball in your hand, passing around, soccer, looking at all the different types of kicks that they do in soccer. So once you can do that within a closed environment, the idea is then to go into an open environment and return to team training. I question mark whether a triple crossover hop is appropriate for a weekend warrior. It's a pretty aggressive test, but I guess if you're within 90% of the unaffected side as an average punter, then I dare say that you're good to go, so long as you hit the other suggested markers there on the right hand side of the screen. So before I go to the case study, I think I might just quickly run through some of these tests. I'll just unshare my screen. You might hear the garbage truck come by now, so sorry for the noise. So you're looking at a single leg squat for reps. So this is probably a little bit low than what we'd normally do, but you're basically testing how many single leg squats you can do for reps on a metronome. So we normally do about 60 beats per minute, and we're keeping to that beat. And then you're comparing it to the other side. And then again, looking at those percentages, 60, 80, and 90% of the unaffected side. 5 coordinated hops are pretty simple. So a coordinated hop is just a normal looking hop. So again, just like that. So uncoordinated looking hop might look like this. That's not a coordinated hop. And obviously you're looking for something that's quite smooth and equal to the unaffected side. Your single leg hop for distance is a pretty simple test that you put down a marker or a line on the floor, and all you're doing is placing your hands across your chest, and then from there launching as far as you can go, landing softly and sticking it, looking at the distance from where you started to where you finished, and then testing your affected side, comparing it to your unaffected side, making sure that your landing is smooth. And again, looking at about 90% of the distance in most cases. And then the other test that we went through was your side hop test. So normally what we do is we put 2 lines on the ground about 30 centimeters apart. And what we're doing is just jumping over those 2 lines and seeing how many reps you can get in 30 seconds. And comparing the amount of reps that you got on your unaffected side to your affected side. That's your side hop test. So they're the tests. And again, if you've got any questions, hit us up at the end. So I'm just going to share my screen again to wrap up. I'm tired now. All right, so going back to the original case study, after day 3, this particular player had passed their weight-bearing strengthening markers. So they did, believe it or not, just 1 day of those rehab exercises after we controlled his swelling on day 1 and day 2 post-injury. And then on day 4, this particular player passed their rehab running markers, and we ran him day 4 and we ran him day 6. So we had 1 day off. So he just did some conditioning on day 5, and that's pretty normal within our rehab markers. And day 7, he returned to train and trained a full session with the Waratahs day 7 and performed the captain's run day 8 post-injury, and he returned to play day 9. So fortunately we had a 9-day turnaround. That's probably one thing that was to his advantage. And secondly, he had a pretty miraculous return given the state and the amount of initial swelling that was in his knee and the state of what it looked like during the trial match, and he returned to play for 70 minutes. He continued with tape for most of the season. So I forgot to mention that during the return to run process and train process, he was always strapped, and the PCL strapping we used was that cross strapping at the back of the knee. I don't know that you guys have probably been on a knee strapping lecture that was taken earlier. But we used a cross strap at the back of the knee just to support the back of his knee, which is, I guess, traditional for a PCL. And he returned to play. Didn't miss a game for the rest of the season and was strapped up for the rest of the season, which was fantastic. So I guess thank you for listening today. The next talk that we'll go through, we can go through the ankle joint, the calf, and the hamstring. and we'll go through the markers for the average amateur player for the ankle, calf and markers, and compare them to the markers that we use at the Waratahs. So I guess for all your products that we used here, please go to your local pharmacy or your local sport wholesaler, or alternatively go to elastoplast.com.au for more support. Question time. I've got one question here. How much time was dedicated to the rehab per day in this case study? So that's an excellent question. I guess in the early stages, when we're just trying to control swelling and we're just trying to get his quads reactivated, you're probably looking at something around the hands-on time, maybe about half an hour. But obviously you can appreciate that these guys use pieces of equipment that they can keep on at night time that involve compression and ice, and they're pretty much at that rehab independently anyway, all day, and in this particular case all night. We set our rehab anywhere between 2 to 5 times a day depending on the particular exercise, but formally we see them for about half an hour hands-on time. Any other questions? So question here was, when do you recommend strapping the knee post-injury or post-surgery? And is that recovery time unusual for PCL? So strapping of the knee. So I would traditionally not strap an ACL, for instance, which is the most common knee surgery that we see after they're fully rehabilitated through our processes. I would, however, very much traditionally strap an MCL returning from even just a grade 1 through to an MCL repair. It's something that would keep the entire time. PCLs I would do early on and then leave it up to the player as to whether they start to wean off tape or whether they keep it on the entire time. I think one that we don't see a lot of in footy is patellofemoral pain, but I believe it's within the private practice setting one of the most common non-acute conditions that you see there, and there are a lot of great kneecap techniques to use to alleviate pain in the kneecap, with respects to specifically kneecap tracking, which your physio can assist with. And that is a very unusual time for a PCL. Now, PCL grade 1, absolutely, maybe we can turn that around in a week. I think that would be not too much to ask for. But I think given this particular player's presentation early on, I thought that was a pretty good case study to present today. Another question here. What would a typical game day at the Waratahs look like for you, both pre-game and post-game? And particularly for players who are returning to play after rehab? Great question. So it depends, I guess, if it's a home game or if it's an away game. So if it's a home game, the boys would get strapped. Let's say the kickoff is 7:40. We'd start strapping and start preparing the players, whether that's flushes or whatever they need, at around 5 o'clock. So 2 hours and 40 before the game. And then we'd cruise through that. We have 3 physios working with us to get through the workload. Our first typical rugby meeting would start at 6:30. So we've got about 90 minutes worth of work before the rugby component starts to kick off. So that's your team meetings, your game day preps, your unit meetings, etc., etc., etc. From there, you're looking at starting the warm-up at around 5 to 7, which is 45 minutes before the game, and it's a staggered start. So you've got your kickers that go out first, and then your line-out jumpers, and then it goes on from there. And then we return to the sheds around 10 minutes before the game starts, and then we have our final rev up, and then off you go. Post-match, we'd go through our medical routine, hopefully sing the victory song, have a feed in the change room, and be on our merry way. The only difference in an away game would be that we'd probably prepare a little bit more at the hotel, and then arrive at the game at around 6:15 traditionally, and have all the strapping done at the hotel prior to it, and then get straight into a meeting. Another question here. What knee injuries? Oh, sorry, I didn't answer the other second part of that question, particularly for players who are returning to play after rehab. So, well, there shouldn't be any type of change for people returning to play after rehab. They should just follow suit with the team. There might be restrictions with their game time, and that's a collaborative decision with strength conditioning and the rugby staff. They just follow suit. There's no real change unless they need extra preparation with their activation, with flushes or whatever else they need, strapping, wherever else they need. The next question here is, what knee injuries tend to take longest to rehabilitate, and are all injuries tested the same way prior to returning to play? Are there certain injuries that it's harder for independent marker approach to be applied to? Solid question. So I guess traditionally the longest and the most common that we see is the ACL, but you do get more complex knee conditions like patellar tendon ruptures, which can take a little bit longer. We've also, this particular player, believe it or not, had an ACL tear about 3 years prior to this PCL, and had an osteotomy, which is basically a realignment of his tibia. And at that time, was the only rugby player to ever have one, and that was a 12-month return to play. And that takes, obviously, it's probably the longest knee rehab that I'm aware of. Are they all tested the same way? No, absolutely not. So a marker brace approach is good within a layman setting, but there needs to be scope to be flexible within a professional setting. For instance, with the ACL, we start to use cameras and analysis through force plates to determine whether one is safe, whether their return to play is at an acceptable risk level within the physio, medical, strength conditioning and rugby department. And we wouldn't go through thorough testing like that, for instance, with a PCL or an MCL, but we would do that with an ACL. Are there certain injuries that it's harder for independent markers approach to be applied to? Yeah, as I said, absolutely, and that's a great question. Markers are only good within some situations. Hopefully, within these markers, it's blanketed 80 to 90% of conditions. But there are certainly other injuries that have their little particularities, I guess, I don't even know if that's a word, that don't follow the independent marker approach. Another question here. For an amateur player, what advice can you give to help aid rehab during day-to-day working life? Would you suggest wearing a brace of some sort? Great question. So in your working life, it depends what you do for work, I guess. So in the early stages, if your injury is acute and it's resulted in swelling, etc., certainly if you needed support around your knee, that might be worthwhile. Even if it just aids your perceived level of confidence and reassurance within the joint, I would say that would be worthwhile. Don't underestimate the value of ice and compression, and those braces do provide compression in a day-to-day setting with work. I guess as you continue to progress through your rehab, the more, and your knee's relatively pain-free, the more active you are, I dare say, in most cases, depending on, the more active you are, the better it is for your knee. For instance, if you're sitting down all day and you're dealing with chronic patellofemoral pain, it's probably not fantastic. It's probably best to keep up and moving. Yeah, so hopefully that answers your question. Another question here. How frequently are baseline markers tested per year? That is 1 rep max range of motion. Oh, great question. Great question. I think it really depends on the program. I've been at the Waratahs for 10 years now, so it really depends on who's leading the program. But if you're going to take baseline markers, the most important thing is, I think, in my opinion, is to retest those markers after a period of time, so you know that what you're doing is the right thing. So if you're testing a baseline early on as they come back from post-season, and then you put them through a pre-season, and then the aim is there to reassess that at the end of the pre-season. It gives you a fair idea, let's say, from a strength perspective with 1RM maxes, and let's say conditioning tests, that they've had a successful pre-season. I think when it comes to physio stuff, we would test them once a year, just to see how they are. And we at the Waratahs prescribe our correctives or our individual exercise to target certain deficits, primarily based on past history, but also for glaring deficits on screening. And we'd do that once a year, and within those glaring deficits, retest throughout the year to make sure that they're, one, doing their exercises and they're accountable for that, and two, whether we're making progress with the exercises that we've prescribed them. So again, it depends on the condition, depends on the test. But a great question. There's some conflicting arguments out there regarding the use of ice in acute management injuries. Just wondering your view on this. I haven't seen the argument the other way. I would say that for pretty much all conditions, I would ice up a joint. I would say maybe there's some conflict with spinals like backs and necks, whereby ice is typically not something that we would do routinely, and they may respond better in time to maybe a hot pack or something. But within your peripheral joints, I would be pretty much putting ice on most things, and within your soft tissue injuries, I'd be putting on ice for most things. All right, that's it. That's all we've got time for today. So thanks for tuning in. Hopefully you can tune into the second talk that we've got, and the rest of the talks on the Elastoplast taping and movement series. I want to thank everyone that has logged in tonight. I do hope the session has been worthwhile, insightful, and useful. And if you need more information, please go to elastoplast.com.au for more information, or visit Elastoplast on Facebook, Instagram, or LinkedIn. So thanks very much, everyone.